Esteemed members of the profession, good evening. Welcome to today's session. If you can hear me, just send a hi on the chat and let us know which branch you're joining us from today. All right, I see you can all hear me. Good evening, Dennis, Dr. Dennis Mbuve from Nairobi, Dr. Teresia Kinyanjui, good evening. Dr. Wandera, Dr. Betty, karibuni sana. Welcome to this session. So I see we are now at 403 participants. So we'll just dive into the session. So I'll just take you through the ground rules and announcements for this session. And first is to let you know that we're going to be muted for the entire course of this session. And if you have any questions, kindly utilize the Q&A tab, which is at the bottom of your window. And the questions are going to be addressed by the presenters at the end of the session. For those who have not subscribed on the PPB portal, kindly go to the PPB portal and search for the keywords birth or life after birth webinar, and you'll be able to find the events. This video is being recorded and it will be made available on the PSK YouTube page after this session. Thank you so much. At this point, I'd like to welcome Dr. Kadare, who will be moderating this session. Dr. Kadare, can you hear me?
Yes, Dr. Hezron, I can hear you well.
Right, welcome, Dr.
So thank you so much, Doc, and my colleagues. I want to take this opportunity to welcome all of us in this very high-profile CPD or CME section for pharmacy professionals. And I want to say thank you for joining the meeting. Today, I think we have our presenters. We have Dr. Ruth, is our ops guidance specialist. We also have Mr. Mike and Sam. So I think they are going to do introduction. But what are we looking at today, even actually as pharmacists? I think our topic is life after birth. And all of us as pharmacists, we know the role that we need to play, and we all want to play in terms of the issues of birth and actually BPH that we are actually trying to champion today. Postpartum hemorrhage is actually some of incidences that we have encountered as pharmacists in terms of the case presentation, in terms of interventions, in terms of medications that are needed to prevent BPH. And actually, this is the right time for us to even check all that is at our disposal in terms of procurement, in terms of selection, in terms of prioritization, in terms of distribution and use. And even after that, checking on the medication-related problems in BPH indications. So I think today is a very good opportunity for us to learn, to listen, and actually to contribute and ask questions where we need to do. I want us to remember as pharmacists, we are now coming up and joining the primary care network, which is very critical for us. And primary care network and actually team player is where we need to be at the ground level in terms of detection and even prevention. And we will be very key in terms of drug selection, procurement, distribution, and actual use, and even quantification and justification in terms of efficacy and authority. So, ladies and gentlemen, we are going to welcome our presenters today. And I think I'm going to welcome Mr. Mike, who is going to invite Dr. Ruth, and then we start our presentation. Mike, can you hear me?
Yes, I can hear you very well, Dr. Kadare, and thank you very much for giving us this opportunity to share with you a few thoughts around prevention and management of postpartum hemorrhage. My name is Michael Muthamia. I lead the AMPLI PPHI project, which is accelerating measurable progress and leveraging investment for PPH impact. So with me, I have Dr. Ruth Omai, who will introduce herself, and Samuel Kibonge, and then we proceed with the presentation. So welcome, Kibonge, and then to Dr. Ruth.
Thank you, Mike, and Dr. Kadare. Good evening, everyone. My name is Samuel Kibonge. I work with PAZ as a market shaping officer in this project. And I had it to Dr. Ruth. Thank you.
Okay. Good evening, everyone. My name is Dr. Ruth Wamai. I'm a consultant obstetrician gynecologist, and at the AMPLI project, I am tasked with the role of advocacy, where we work under the with COGS through the guidance of FIGO to raise awareness and drive advocacy in terms of PPH. So I'd like to welcome everyone to this webinar today, and I hope you're going to have a good time and a very good learning experience, and an experience where you'll also be able to give us feedback and we can share. So welcome to today's webinar. So why are we here today? Postpartum hemorrhage is actually the leading cause of maternal mortality. And annually, about 14 million women will actually experience PPH, resulting in about 700,000 deaths. Unfortunately for us, 90% of these deaths will actually be occurring in low and lower middle income countries where Kenya falls. Kenya is a LMIC according to how it's categorized. So the death of a mother is a catastrophe for her children, her family, and the entire community. But the global initiatives which have been working on postpartum hemorrhage have largely failed to set the stage for a comprehensive ecosystem for PPH, which is what AMPLI PPHI project is now trying to do. Next. So how about our Kenyan experience? In Kenya, about 2 out of 5 women, which is 40%, will actually die due to obstetric hemorrhage. And 91% of these women who die will have received suboptimal care. So heat-stable carbetocin, tranexamic acid, and misoprostol are newly introduced PPH prevention and management drugs, which can actually help change the trajectory of postpartum hemorrhage-related mortality. But until these medicines are sufficiently incorporated into our supply chains here and integrated into our national clinical guidelines and also trusted by users in terms of proper use in the real world settings, WHO guidelines will not achieve full implementation, and then we'll continue having, having mothers die while giving birth. So there has been a widespread problem with the quality of uterotonics, and maybe the pharmacists can help us with this. We've had several studies which have studied the quality of uterotonics like oxytocins, systematic reviews in 40 LMICs, which actually had 19 studies on PPH drugs, and actually showed 75% of the ergometrin, 39.7% of oxytocin, and 38.7% of misoprostol have actually failed quality tests. And recently we had a study in 2022, and samples were collected and analyzed according to international standards in Kenya, Nigeria, South Africa, and Tanzania. And this was done during a large PPH trial called Emotive, which happened recently. And they actually found only 6 out of 17 unique oxytocin products had actual adequate content and no related substances, which were exceeding recommended limits. And then 10 out of 14 tranexamic acid samples were the ones that actually passed the test. So this is actually very unfortunate and can lead to death. Next. So in summary, our project, also known as AMPLI in summary, accelerating measurable progress and leveraging investments for PPH impact, where we hope to catalyze early adoption and scale up of new and recently recommended drugs to prevent or treat PPH in the high burden countries as part of an integrated package of PPH. So the medicines which have been introduced into the package include heat-stable carbetocin, tranexamic acid, and misoprostol, especially in areas where women are unable to reach facilities to deliver. The project will run for over 48 months. It started in August 2022 and will run until July 2026. So we have 4 target countries, which is DRC Congo, Guinea, India, and Kenya, And with the experiences that we're going to collect in Kenya, we hope to exchange our experiences with Tanzania, Uganda, South Africa, Rwanda, and Ethiopia. So we'll be actually causing a lot of influence around the region. In Kenya, the project will be happening in Makueni in 36 health facilities. And the partners include JPIGO, PATH, and FIGO, represented by COGS here in Kenya. So I'll give an overview of postpartum hemorrhage and a few clinical tips on how to manage it. So postpartum hemorrhage has been defined as a blood loss in excess of 500 mL in a vaginal birth and in excess of 1,000 mL in cesarean delivery. But for clinical purposes, any blood loss that has a potential to produce hemodynamic instability should actually be considered as PPH. Clinical estimates of blood loss are often inaccurate, and I hope one day we'll get a chance to also discuss the emotive trial, which really studied the effect of having to measure blood. If you're able to measure blood loss accurately, then you're able to institute management at the right time. So if you use time, primary PPH is bleeding that occurs after delivery of the baby up to the first 24 hours. And secondary PPH is any bleeding which will occur 24 hours up to 6 weeks postpartum. Especially this is due to retained products of conception or infection, sepsis, or maybe both. And refractory PPH is PPH which is actually not responding to standard medical management with using uterotonics, or non-medical management like uterine massage, bimanual uterine compression and compression of the abdominal aorta, or repairing of lacerations or any other traumatic injuries, and manual uterine revision. So sometimes when you have refractory PPH, you may end up having to use surgical means like doing uterine artery ligation or doing a hysterectomy. So the 4 known causes of PPH, we call them the 4 T's: tone, trauma, tissue, thrombin. But as a gynecologist, I can tell you, when you're having PPH, 70% of the time, your PPH will be occurring because of tone. If you're able to actually solve tone, you'll be able to even remove the tissues, because if you cause the uterus to contract, you will solve the problem of tissue, and you will actually prevent the patient from progressing from PPH up to DIC, thrombin. So 70% of your problem is tone, 20% is because of trauma, 10% is retained tissues, and the rest, 1% is because of thrombin. So every woman is actually at a risk of developing PPH. Sometimes the woman you think will get PPH is the one who doesn't get, and the one you're not expecting is actually the one who gets. So it's always good to be ready. But just in case, if you have a patient with anemia, a patient with a pre-existing coagulation disorder, has had antepartum hemorrhage, maybe because of a placenta previa, prolonged labor, and largely distended uterus, maybe because of a big baby, polyhydramnios or multiple pregnancy, a grant multipara, like she's on her 6th delivery, someone with fibroids, someone who has been induced and augmented for a long time in labor, previous placenta previa, previous retained placenta, a previous cesarean section, anyone with sepsis, then heading to delivery, or a full blood after delivery will expose a patient to developing postpartum hemorrhage. So how do we prepare? We know the definition, we know how to pick it up. We have charts that we actually use, the MEOS charts, where you chart the patient's vital signs. You should have regular emergency drills within your facilities, multidisciplinary approach. The gynecologist, the nurses, the people in the pharmacy should give us the uterotonics. People in the lab should have blood prepared. So all these things and any other things in the system that help you manage the mom. I'd like to draw attention to the PPH kit, because this is where I think pharmacists can really assist us. This kit, a PPH kit, sometimes you can have a mobile bag. It doesn't have to be a big kit like this, but you can help your facilities prepare a PPH kit with the required contents, which you can share the list later. But this kit should be adequately supplied and kitted and ready to be moved around. It should actually be a mobile unit, because a mother can deliver anywhere. Then, of course, having blood and blood products and the rest. So national documents currently have actually been updated with the WHO recommendations. So in Kenya, we have actually adopted what is currently recommended. And in settings where oxytocin is unavailable or its quality is not guaranteed, like the studies we have just seen, heat-stable carbetocin can be used. Also, you give 100 micrograms IM for vaginal births or IV slow infusion for cesarean section over 1 minute. Then you can also, tranexamic is also now recognized as a drug for treatment of postpartum hemorrhage. You give 1 gram slowly over 10 minutes within 3 hours of all births that develop postpartum hemorrhage. So these are the current WHO recommendations. Oxytocin remains our number one recommendation, but in cases where oxytocin is not available, okay, oxytocin, you give it at 10 international units, IM or IV, and it's recommended for the prevention of PPH for all births, either vaginal or cesarean section. Carbetocin is a second line. Use of carbetocin 100 micrograms IM IV. It's recommended for the prevention of PPH. That means that in the use of third stage of labor, the active management of third stage of labor, you should actually be using carbetocin for all births. Previously, it was recommended only for cesarean section, but after studies have been done, you can now use it in both cesarean section delivery and in normal delivery, especially in contexts where its cost is comparative, or Michael. Sorry, I missed it can be used in contexts where its cost is comparable to other effective uterotonics, and my colleague will actually be discussing more about its use. And misoprostol can be used up to a dosage of 600 micrograms per oral or 400 micrograms, and it's recommended for the prevention of PPH for all births. There is also egometrin and methylegometrin, or the combination of oxytocin and egometrin, what we sometimes call symptometrin. So these are alternatives, but their use should also, you should use it in patients where you have safely excluded hypertensive disorders. So like what Dr. Kathare was saying, we are all working in different levels, facilities. We should at least make sure we have a whole, armamentarium of management of PPH. We have injectable prostaglandins like carboprost. Carboprost is not recommended for the prevention, but it's recommended for treatment of PPH. So active management of third stage of labor should be offered to every woman at the end of delivery. But first, before you inject anything, you have to palpate the uterus to rule out additional babies. And then you give the uterotonic drug within 1 minute of childbirth. So which uterotonics would you be having available? If you have oxytocin, you can give oxytocin, 10 international units IM, even if the labor was induced or augmented with oxytocin. If you have no contraindication, you can then come and give, your alternative can be heat-stable carbetocin, 100 micrograms IM for vaginal delivery, or IV, slow IV for cesarean section. If you do not have that, you can also give misoprostol, 600 micrograms, which is 3 tablets of the 200 micrograms orally. And if the patient has no contraindications like preeclampsia or cardiac problems, you can use egometrin if you do not have the other ones. So of course, the other actions of third stage of labor is to deliver the placenta by controlled contraction on the umbilical cord and counter pressure on the uterus. And you massage the uterus until firm and contracted, and then every 15 minutes for 2 hours. So my colleague, Michael, will be discussing more about the new molecules which have been introduced into the guideline. Thank you, Michael.
Thank you very much, Dr. Omai, and thank you for laying a solid ground on PPH. So I'll take a few minutes to talk about heat-stable carbetocin and a few other medicines and innovations that are being introduced to prevent and manage PPH as the leading direct cause of maternal mortality. So when we talk about heat-stable carbetocin, it's good to note that there are many forms of carbetocin in the market, but we only have one heat-stable molecule. That is the carbetocin ferrin. That is the only one that is heat-stable. So as you procure, please take note that there are many in the market, and it's important to know the one that is heat-stable. So why heat-stable? We've mentioned that majority of the deaths occur in the low resource settings. And unfortunately, our standard of care, which is oxytocin, requires cold storage at 2 to 8 degrees Celsius across the supply chain. And we know that in our environment, this is a challenge because we have a fragile cold chain system. A study that was done in 64 countries showed that 22% of the facilities that were surveyed did not have refrigerators. You also are aware of the challenges that we face, especially recently when we had a serious blackout, and that definitely affects the quality of oxytocin, among other drugs. So this molecule can be stored at 30 degrees Celsius, and it can be used within 48 months at that temperature. And it does not require refrigeration, and therefore it leaves the burden of cold chain, especially in our environment. So other than the temperature requirements in terms of storage, each stable carbetocin is different from oxytocin. And one of the major differences is that carbetocin is a long-acting synthetic analog of oxytocin, so it acts longer. If you compare the duration of action of oxytocin, which is around 30 minutes, compared to its stable carbetocin, which is around 119 minutes. So that is 4 times the duration of effect of its stable carbetocin compared to oxytocin. So WHO has already recommended its stable carbetocin for PPH prevention in all births. Please note that we are using it only for prevention. We know that there is off-label use for management, but that is not recommended. As yet, their study is currently being implemented by WHO and other partners to confirm whether it can be used for management. But for now, we are sticking to the guidelines that it can only be used for prevention. So it has been added into the WHO model list of essential medicines and approved by the Swiss Medic. That is a stringent regulatory authority. As you can see, that is the WHO essential medicines list, and it's right there. So the mechanism of action is similar to that of oxytocin, that is binding to oxytocin receptors and stimulating myometrial smooth muscle contraction. But the major difference is that the duration of uterine activity is much longer, as you'll see in a few minutes. So just as a way of emphasizing, you only need 1 single dose for a patient, and therefore it eliminates the need for multiple doses. I know that happens very much with oxytocin. And according to a network meta-analysis conducted in 2018, its stable carbetocin is the highest ranked single iterotonic agent for PPH prevention for blood loss above 500 mL. And its stable carbetocin may reduce the need for additional iterotonics, especially because of the length of action. And in terms of the side effect profile, its stable carbetocin and oxytocin side effects are comparable, and they have the most favorable side effect profiles compared to other iterotonics, just like Dr. Wamai has mentioned. And again, as per the meta-analysis, each stable carbetocin has the most favorable side effects profiles, just like I've mentioned. And it is the only iterotonic that is comparable to oxytocin across all the side effect profiles, such as fever, nausea, shivering, and vomiting. The other good thing about its stable carbetocin is that it has a very rapid onset of action. There is 2 minutes for both IV and IM administration, a long half-life and a long duration of action, taking around 60 minutes for a single IV injection and 119 minutes for IM injection. And that single injection is what you want. You don't want to have multiple doses. And for IV, you give it slowly over 1 minute. So having only 1 single dose makes it simple, because we know that we are strained in terms of our staffing and other challenges within our facilities. Yeah, so this is a chart that is comparing the concentration time curves for IM dosages of each stable carbetocin compared to a correctly stored oxytocin. As you can see, the difference is huge in terms of the duration of action, which is also shown in this chart, that each stable carbetocin duration of action is around 119 minutes compared to 30 minutes for oxytocin. So it gives 4 times longer duration of action than oxytocin. So in terms of administration, it's important for us to have a conversation around it. So we talked about the mechanism of action, which is similar to oxytocin, binding onto the oxytocin receptors and activating the rhythmic contraction of the uterus and increasing uterine tone, as well as facilitating placental separation during birth. So this is emphasis. I think I've already talked about that. So each terbinafine is approved for prevention of uterine hemorrhage due to atony. Uterotonics are used for atony, and it should only be administered after delivery of the infant. That is within 1 minute of the delivery of the infant, and after ruling out that there is no other infant or baby within that uterus, because it gives such a strong contraction. So if you make a mistake of giving it in advance, you're sure to lose that baby because of the strong contraction. Actually got an opportunity to test around 9,000 doses under the Smart Mothers project. And the midwives who used it told us that the contraction that this medicine is giving is so strong, like what they used to see with the Cometrine. Very strong contraction that starts almost immediately. Again, it should not be used for induction or augmentation of labor because of that long contraction that it gives. Again, it should not be used during pregnancy or before birth, or even in women with serious cardiovascular disorders, like most of the drugs, as well as patients who have hepatic and renal disorders. Again, it should not be used in women with epilepsy or women who have any hypersensitivity to any of the carbetocin, oxytocin excipients. So this is just emphasis that you should never give carbetocin before birth of the infant, because that is a contraindication. Again, always rule out a presence of another baby. There is multiple gestation before administration. So in terms of packaging, this is a molecule that comes in a pack of 10 ampoules. So we have one that is in the private sector, which is called Pabal. It's quite expensive. I know that is what has been available in KEMSA. But as my colleague Bonge will talk to you about in a short while, we have a market access product that is carbetocin ferring that should be available in the public sector. So it has a package of orange, as you can see, so that it can be separated from other uterotonics. And each ampoule has 100 micrograms of carbetocin, in addition to other chemicals, as you can see down there. So the solution should not be diluted, and ideally you should use the 2 ml syringe as you administer it, and 1 ampoule is only for 1 patient, and administration of multiple doses is not recommended. So we talked about for IV, you give it slowly over 1 minute. And one very important point is that we should not inject carbetocin in the intravascular fluid bag. And I'll also share a slide that shows that we should not do that also for tranexamic acid. So it's important for us to avoid mixing medicines in the IV fluid bags. So for injections, same dose, 100 micrograms, IM. So another important point is that carbetocin can be administered for PPH prevention, even if other uterotonics were used during labor. So if you use oxytocin for augmentation or for for other procedures, then you can still use carbetocin for prevention of PPH. So that is an highlight of carbetocin. I know my colleague will talk about its access in a few minutes. So the other molecule that we've talked about is tranexamic acid for PPH management. And back in 2017, the World Health Organization updated its guideline on the use of tranexamic acid for PPH management. So there was a 2012 guideline that said that tranexamic acid should be used for treatment of PPH in cases where the cause is trauma. But that guideline was updated in 2017 to say that tranexamic acid should be used for all PPH cases despite the cause. Again, tranexamic acid should be used within 3 hours of birth. You should give the first dose within the first 3 hours of birth, and the first dose should not be given after 3 hours of birth. And it's also important to note that for tranexamic acid, we are not using it prophylactically. Instead, we only use it when we are treating PPH. So this is a molecule that has been around for many years, all the way from 1957. It's an antifibrinolytic agent that inhibits enzymatic breakdown of fibrinogen and fibrin clots with a half-life of around 2 hours. So this is the difference that I've talked about in terms of the 2012 recommendation and the 2017 recommendation. And the good thing is that the Ministry of Health has adopted this recommendation within our guidelines. So we have an opportunity to make sure that we manage PPH using tranexamic acid. Under the Smile for Mothers project, the major challenge that we noted is that the majority of facilities did not have IV tranexamic acid, which is what is recommended. We are not using the oral, we are using the IV formulation of tranexamic acid. So as pharmacists, we can help the country by making sure that we have that IV formulation of tranexamic acid. So the drug is administered at a dose of 1 gram slowly over 10 minutes. And in case bleeding does not stop within 30 minutes, you can give a second dose, or if bleeding starts within 24 hours, you can give a second dose. But important is that you should not give the first dose after the first 3 hours of birth. And the reason is that beyond the 3 hours, it does not confer clinical benefit, and the suspicion that it might cause potential harm to the patient. Again, tranexamic acid should be given as part of the standard care of PPH management. It's not a replacement of oxytocin. It's not a replacement of uterotonics for PPH management, but it should be a part of the care. Again, we should avoid tranexamic acid in situations where there is obvious contraindication, especially against antifibrinolytic therapy. So the other important point is that we should not give tranexamic acid through the IV bag, especially where there's oxytocin. Do not mix them, because there are some interactions that have been demonstrated, and I'll share with you shortly. Again, it should not be given rapidly. That is why we are giving slowly over 10 minutes. That is 100 milligrams per minute to make a gram for the 10 minutes that the recommendation is, because if we don't do that, we are likely to get into hypotension. These are some of the contraindications, as you can see: DIC, renal disease, vascular disease, subarachnoid hemorrhage. Yeah, so I want to bring to attention some interaction that has been noted. It was noted under the emotive trial. And what was tested was a treatment of postpartum hemorrhage, compatibility of oxytocin and tranexamic acid when they are mixed in vitro in the IV bag. So it was noted that there was significant interaction between certain brands of oxytocin and tranexamic acid after mixing them in vitro and observing them for 1 hour. And the interaction substantially impacted on oxytocin content, reducing it by up to 29% at 0 minutes. So it was clearing the oxytocin. And therefore, it's good to create that awareness that we should not mix tranexamic acid and oxytocin in the same IV fluid bag, because we may end up underdosing the patient, especially in terms of oxytocin. Yet the tranexamic acid will not do what oxytocin can do. This is a drug that should be stored at room temperatures. And again, I want to bring to your attention some catastrophic drug errors that have occurred between tranexamic acid and bupivacaine. As I mentioned, tranexamic acid has been around since 1957. And between 1960 and 2018, there has been 21 cases where tranexamic acid was used erroneously, that is intrathecally, in place of bupivacaine. So somebody took tranexamic acid thinking that it was bupivacaine, and they administered it intrathecally. So that's a fatal medical error. And out of the 21 cases that have been picked in literature, 10 of those patients died, and the ones that survived developed serious neurological and cardiac complications. So as we advocate for increased use of tranexamic acid, especially in theater, facilities need to have strategies to separate tranexamic acid from bupivacaine as advocacy efforts continue on better packaging of these two life-saving medicines. So other than the two medicines that I've talked about, there are two other medical devices that have been prioritized for prevention and management of PPH. And the first one is the non-pneumatic hand-shock garment, which is a device that helps in improving the patient's hemodynamic stability, especially by pushing the blood from the peripheries to the vital organs so that it can prevent shock. So it's a very affordable device, less than 15,000. And this is something that as pharmacists, you can prioritize for your facilities so that instead of seeing a patient die, you can be able to have this garment, wrap them in the garment. There's a video that you can watch later so that you can be able to stabilize them in terms of the hemodynamic stability as you continue doing other interventions. Again, there's a new device, the free flow UBT. I know we are used to the condom balloon catheter, but the Ministry of Health has prioritized this free flow trained balloon tamponade that has an advantage of releasing the fluid as the uterus contracts, and there are materials that you can get on now to use it. So at this point, I want to invite my colleague Kibonge to talk about access. So how do we get these medicines, especially at market price, and what efforts have we put in, or has the ministry put in, to make sure that these commodities are available for our public sector? Over to you, Kibonge.
So thank you, Mike. We'll look at commodity access, and we'll look at the key aspect of commodity access, and we'll look at affordability. Is it affordable to patients? Availability, is it available to all patients who need it? And also look at assured quality. Those commodities in quality as recommended by the regulatory bodies, and appropriate design. And finally, awareness, what we are doing, healthcare providers aware of their use. Then we'll look at the progress towards availability of histobocarbetocin in the public supply chain. And to start with, there's an inclusion in the national guidelines, and which for histobocarbetocin has already been included in the national guidelines. Registration of access histobocarbetocin. The histobocarbetocin, as Mike mentioned earlier, is currently in the commercial. It's currently under commercial price, and Kenya has made strides towards registration to its access. That was done last year. And the other important step is determination of needs through quantification, which I know most of the members were involved in terms of the forecasting quantification for this histobocarbetocin. Just to mention that the estimate requirements under that forecasting quantification exercise was for financial year 2023-24 was over 555,000. And which brings me to the next point that KEMSA already intending to procure 360,000 ampules, and hopefully we'll have them in the country soon. The other part is creating awareness in readiness for Project Arrival, which now, as a project, we will be sensitizing the key professionals. The other aspect is advocacy for purchase and safe use. Just also to mention that the negotiated prices for the ampules would be getting for the public health facilities and FPUs, they might be getting at less than $1 per ampule, which I think would be a good progress comparing to the commercial one, which I think currently reaches around $27. Then what our call for action? Call to action is one is value-based procurement. So we adopt procurement practices based on the total value of the drugs, rather than solely based on the prices of the drugs. And look at other values, for example, reduction of the total health cost, and also improvement of patient outcomes, so that we don't solely procure drugs based on the prices of the drugs. I know pharmacists are the key guys in procurement of health product and technologies. I know you'll be able to support in that. And then the other call of action is advocate for procure and procure quality assured medicine. Then disseminate updates on PPH prevention and management. And the other call of action is plan to include histopocabetocin in the intratonic mix once available in the public procurement agency, and also in meds. And also procure quality assured IV tranexamic acid for PPH management. And the last call to action is strengthen pharmacovigilance reporting and response, so that we can be able to continually monitor the quality and also the effects of this medicine. And that's all. I hand it back over to Dr. Kadari. Thank you.
Sorry, Dr. Kadari, you are on mute. We can't hear you.
Oh, sorry. I'm saying thank you so much, Dr. Ruth, Mike, and Sam. I'm saying that this has been a very enlightening CME than the ones we are used to have, because it's trying to remind pharmacists the history of anatomy, more so embryology, and actually the interventions that we ought to be making. So just before we go to QA, I just want to mention a few things that we have been able to highlight. One, as pharmacists, I think it has come clear that we need now to start preparing PPH kits. This is very interesting, because in our practice, we have never thought something like that. So in the entire county, we can prepare PPH kit in our pharmacy and actually be able to monitor the way we monitor DDA drugs in the ward, in the maternity. I think it can be of great help to the entire healthcare team and our colleagues. We have tried to look at the quality. When we have research and data presented, I think it helps us to make decision as scientists. We have tried to see the comparison between the tranexamic acid, which all of us, we are familiar with the molecule, both the IV and the tablet and in the oral forms. We are also familiar with the misoprostol, which actually is a viral, which is actually under our custody. Maybe carbetoxin, maybe probably the one that we are not being able to stock. But because now we can understand stocks are actually landing in KEMSA, we now need actually to do a lot of reading and be able to champion in terms of the efficacy and superiority in comparison to the other molecules that we have. These three drugs, we are familiar with them very well. And in terms of pharmacokinetics and dynamics, I've seen Mike was trying to enter in that area, but we are able to educate the gynecologists and the ones that we are working together. It is the first kind of presentation that has been able to remind us, when I keep on saying we need a specialty in OBS-GYN, a pharmacist, who is able to work with Dr. Ruth and other OBS-GYN in the country, specialists, and be able to guide on, especially on what even Mike has said, the route of administration, the formulation of these drugs. So we need to actually look at this area of OBS-GYN specialty in pharmacy, and they can work hand in hand with the gynecologist in various hospitals that we are working in. We have also seen something that somebody did a mistake in terms of route of administration, especially epidural route with tranexamic acid. These are medication errors. And as I keep on saying, we have medication errors occurring all over, not even in theater, OPD, inpatient, in maternity department where we don't step, okay? You can see the standards demonstrated a medication error. So if we have a pharmacist there to guide on the correct choice, the labeling of the drug, identification of the drug, the reconstitution aspect, then we're actually going to contribute a lot in terms of fighting and preventing PPH. So thank you so much, Dr. Ruth, Mike, and Sam. We have also seen the quantification which was done nationally. And as a pharmacist, we are aware about the review of essential medicine drug list that we have been having. There are so many changes which have taken place. I'm sure now we are aware that even the carbetoxin is available in some of the levels in the facility level 4s, and we are trying to see if it to go all down to the other level 3 and other levels. And this is where we need pharmacists and even our colleagues who are working the level 3s, PharmTechs. We will need to be able to be champions of these drugs and advise accordingly and do the right procurement and the right distribution. And then we look at the justification and accountability at the use level. So I think we have learned. I want to challenge you to go back and look at the embryology, check the steps and the areas where teratogenesis can happen with most of the drugs. And also I think Mike has told us there is no interaction standing with the carbetoxin and other drugs. I think that is an assignment they can give us. We go and check on the interaction with other drugs concerning the carbetoxin. So I think we can now go to question. Dr. Heze, are you there? Dr. Hezron.
Sorry, Dr. Kadari, I see Innocent is ready to has his hand up, so he can unmute and speak, followed by Adajmin Mustafa. Please proceed, Dr. Innocent, please unmute and speak. Yeah, so I think I see some few questions in the chat. Allow me to take a few of those. So the first question is, can oxytocin be used in a patient that does not respond to carbetocin? The answer is yes. In cases where the patient developed PPH and they've been given each stable carbetocin, then you can use oxytocin for management. So I see a question, which is the recommended IV fluid for use to administer the slow tranexamic acid. So it's supposed to, it comes in a solution of 10 ml. So that is what you push slowly over 10 minutes. So you don't have to dilute it. You just need to administer it slowly over 10 minutes. It comes with 10 ml solution.
Michael, I see a question on what are the effects of combining oxytocin and tranexamic acid. They should not be combined. There was a study that actually showed when you combine them in the same IV fluid, then you actually reduce the effectiveness of oxytocin. So they should not be combined.
Yeah, so there's also another question here. Maybe Dr. Ruthi can take that. In facilities that cannot manage PPH, how long can we arrive to an opinion or a medical referral? Dr. Ruth, do you want to take that?
Okay, so I would suggest for at least they should have something. Okay, what is the reason making them unable to manage PPH? Is it the healthcare provider that they do not have adequate staffing, or is it the availability of the uterotonics? So if it's the uterotonics, at least you should, after third stage of labor where you've given the IM syntocinon, oxytocin 10 units, if you feel like the patient is progressing into PPH and you've done your charting of the vital signs and you notice maybe the blood pressure is going down and the pulse is rising, so you're picking signs of shock, then you should actually put the patient onto the anti-shock garment that Michael presented and arrange for quick referral. So if you're in a facility that you feel you cannot manage PPH, then you should know maybe the distance between you and your nearest, at least somewhere with like level 3, a place that can offer emergency care.
Thank you for that. So every facility can do something about PPH prevention. There are very many options, all the way from uterotonics to IV fluid resuscitation, to massaging the uterus, to stabilizing the patient by giving fluids, tranexamic acid. So most of these things can be done within the low-level facilities, and we are advocating for PPH drills within these facilities, and also making sure that we have mentors. So the ministry has developed a very nice training package, the IMOC mentorship package, that can be used for building the capacity of healthcare providers across all levels of facilities. So I see somebody requesting for the slides, yes, that we can share. Okay, so I have heard that one of the approach towards availability of carbetocin is advocate for procurement of this product by KEMSA. We know the niche that these two serve. How is this approach feasible when the molecule is not in MOH 647? We know that in MOH 647, we have oxytocin as a trace MNH product. And I believe as we move forward, there'll be advocacy to have more. But the fact that it's not in the MOH 647 doesn't mean that it cannot be procured by KEMSA. It can still be procured and distributed to our facilities. What is the price of carbetocin affordability at public health facilities? Kibonge, do you want to respond to that?
Yes, the negotiated price would be less than $1 when it's available in KEMSA and NITS.
Yeah, thank you. With the recent blackout experience countrywide, how can we ascertain our oxytocin product stability in our facilities? For sure, that's a huge challenge. But each stable carbetocin is not coming to replace oxytocin. There's a place for oxytocin in terms of PPH management. and induction and augmentation of labor. But the ministry has envisioned that they want to use at least all the PPH, all the deliveries receive around 60%. 60% of deliveries, the plan is to use 60% for each stable carbadosin in terms of the forecast and the quantification processes that we had, so that we reduce that risk. Then again, PPH has been the leading killer for the longest time. So it's time also we do things a bit different, so we can get better outcomes. Yeah, so what is the difference in onset of action between HSC and oxytocin? Just like I showed, the onset of action is almost similar. The major difference is the duration of action. Within 2 minutes, but the duration of action for each stable carbadosin is long 119 minutes compared to 30 minutes for oxytocin. So Dr. Kadari, I see like we've exhausted the questions within the chat. I want to hand it back to you.
Thank you, Mike. So I think we don't have any other question unless we have any reaction. Anyone, please? With a burning point. So to this end, colleagues, want to thank you so much for attending this webinar. We are so much grateful. Thank you so much. Thank you so much, Mike and Dr. Ruth and Sam. Actually, for me, I am looking forward on how you can empower our members in various facilities, actually, even including community pharmacies, on how to develop a PPH kit. I've really liked it so much, like a first aid kit. So I think we will have another forum where we can empower, including every hospital, to have that kit ready for emergency use. I think that was a very good advice. So if we have no any other question, Mike and your colleagues, you allow us to end the webinar. Okay. Now, before that, okay. I may not be able to know, do we have the PSK president with us, or any NEC member, or any NGC member with us, please? Maybe I would like to know whether you are around so that we can recognize you. So I think we have none. So maybe we can now end our webinar. That's okay, Mike?
Yeah, that's okay. And thank you very much. We will be doing some disseminations at county and facilities as we continue engaging. And thank you for the great work you're doing at PSK.
Thank you so much. We assure you, because some of our members who are participating in the MTC, Medicine Therapeutic Committee in our public hospitals, please, when you join the meetings, be able to, don't forget to contribute and to follow up on the product that you have talked about, and advise the other members of Medicine and Therapeutic Committee. Thank you so much, guys, and have a blessed evening, all of us. Thank you.